Hello, and welcome to this month's Simon Says Expert Series. My name is Eileen Allen. I'm a multiple myeloma patient and also an advocate for those diagnosed and fighting this disease. I was diagnosed in 2020 and have been treated here at IU Simon Cancer Center under the care of Dr. Ataya Suvanasanka. As part of my treatment, I had a stem cell transplant in 2020. I was MRD negative following the transplant and have had no detectable disease for the last 5 years. Also, I have been off all therapies for the past 3 years. And joining me today is Dr. Zainul Hasanali, the Daniel and Lori Efroymson Scholar in Oncology. He's a myeloma physician scientist who studies how myeloma starts, how it survives in the bone marrow, and how new discoveries could lead to better, more targeted treatments and treating those that need to be treated earlier. So I'd like to welcome Dr. Hasanali.
Thank you, Eileen. Thank you for the introduction and for the work that you do with myeloma awareness. So the way that we'll structure this is I'm going to give you probably a 15-minute or so spiel about myeloma, sort of how it starts, how it survives in the bone marrow, and then how these discoveries lead us to better, more targeted therapies. And then after that, Eileen and I will do a question and answer session. We'll go through some of the questions that were submitted beforehand and any that come up in the interim. So I know many of you are very knowledgeable about the disease, but just so that we're all on the same page, I'm going to start off just describing what myeloma is before we jump into the rest of it. So again, multiple myeloma is a cancer of plasma cells. So plasma cells are those immune cells that live in your bone marrow, the spongy part between all the hard parts of your bones, where your blood is made. And their job normally is to make antibodies to fight infections. And you should have, a million different plasma cells that make a million different antibodies to fight off any infection you could see. But every once in a while, a plasma cell gets its instructions all messed up, and instead of sitting quietly and making antibodies, it decides to start copying itself. And that's the process that leads to the cancer of multiple myeloma. And because plasma cells make an antibody, we can actually look in the blood for the presence of the specific antibody that's being made by that myeloma cell. So, there should be a million different antibodies that we find, but when one of those copies itself over and over, all of its copies also make the same antibody. And so that's the level that we track in your blood. When we talk about your M spike or your light chain or your IgA or IgG level or IgM level, those are all ways to talk about the antibody that's being made by your disease. And it's great because we're lucky in our disease in that we can use that as a biomarker. So it's very logical. When that number goes up, the disease is progressing. When that number stays the same, it's present but not growing. And when it goes down, the disease is being killed. Now, multiple myeloma, in order to get a diagnosis of multiple myeloma, you have to have the presence of these, we call them clonal cells. So one plasma cell that's copied itself multiple times, and you have to have a clinical symptom. So you may have heard of the term CRAB criteria, C-R-A-B. These are the symptoms that accompany multiple myeloma, and you only have to have one to qualify for the disease. The C stands for high blood calcium, the R for renal dysfunction, so kidney dysfunction. Those antibodies that are made by the myeloma can clog up all the pipes and plumbing in your kidneys and cause them to fail. The A is for anemia, low red blood cell count, and the B is for bone lesions. So that calcium increase is mostly a result of the fact that myeloma encourages your body to destroy your bones because it likes the calcium and the calcium helps it survive. So if you have any of those clinical symptoms and a clonal plasma cells in your bone marrow, then we qualify you as having multiple myeloma. And the clinical symptoms are really important because those are the ones that cause you trouble, and we're really keyed in to treating all those symptoms. So that's multiple myeloma. So let's get into a little bit about how it starts. So I'll talk a little bit about how it starts, like generally like the disease, and a little bit about in a very bird's eye level, some of the genetics associated with this process. So through studies in our veterans population, we actually identify that every case of multiple myeloma is preceded by a precancerous stage. So if you have multiple myeloma, you definitely had a precancerous stage called MGUS or MGUS, monoclonal gammopathy of undetermined significance. And basically what this is some of these plasma cells have copied themselves, but at a really low level, and one that hasn't actually caused you any of those symptoms, any of those CRAB criteria. And so you may ask yourself, all right, if we can see that in people, why don't we just treat it away at that point before it becomes a cancer? And there's a few complicating factors. So turns out that the average age that people get diagnosed with multiple myeloma is almost 70, 69 to 70. And in your sixth decade of life, in your 60s, about 1 to 2% of the population is actually carrying around one of these MGUS spikes in their blood. So it's actually a really large number. So there's millions of people in that age range. And so there'd be tons and tons of people that actually carry this precancerous condition. You may not even know it. Now, if that was the only issue, we could adjust the system and treat these people, but there's an additional complicating factor, and that's that it turns out that only about, on average, you only have about a 1% chance each year to transform from that precancerous state, MGUS, into full-blown myeloma. So what that means is the vast majority of people who have these MGUS, MGUS precancerous diseases will never develop the disease. So now if we treat everybody who's got these MGUS, we're actually going to expose a lot of people to side effects from therapy without any potential benefit. So it's sort of a blurry line, and it's a hard line to walk. We're trying to figure out who is going to be those people that progress. And that's one of the things that my lab looks at. So we're trying to identify things in the genetics of the disease and in the blood markers of the disease to see if we can't pick out who those people are that are actually going to progress to full myeloma and which one of those won't. Then we could actually treat the people that were going to progress with treatments earlier to see if we might be able to cure it before it becomes a problem. So that's still very much in the research phase. Now, how myeloma actually starts, like how does a plasma cell, a normal one that's making antibodies, actually get messed up and start to copy itself rather than do what it's supposed to do? And the real answer is we don't know, but there are some clues. So turns out that about half to three-quarters of these MGUS precursor myeloma cells have a rearrangement of DNA. So DNA is the message in your cells that tells your cells what to do and what they are. And when DNA gets messed up, one of the results can be cancer. So in the case of multiple myeloma in this MGUS state, the DNA gets rearranged, put in a different order, and that somehow predisposes people to getting the disease. We also know that there are certain risk factors, and none of them are 100%. So if you're exposed to these risk factors, it does not mean you will develop multiple myeloma or this precancerous state, but it does mean that your risk to get it is a little bit higher. And those are things like chemical exposures. So multiple myeloma is one of the cancers associated with exposure to chemicals like pesticides, benzenes, if you work in a chemical plant, soldiers that have been exposed to things overseas, fighting, burn pits, water poisoning events. These sorts of things increase the risk of multiple myeloma. But again, most people who have those exposures will never develop the disease. Obesity is also a risk factor for multiple myeloma, as well as autoimmune diseases. The reason for this is not totally clear, but may be linked to the fact that anytime that the body is inflamed, which occurs during obesity and autoimmune disease, your body makes a lot of plasma cells. So perhaps that just gives it a chance to create a plasma cell that has a DNA mutation or a rearrangement in it that can lead to disease down the line. The reasons aren't clear or clearly stated, but we know that some of these risk factors exist. We know that African Americans have a higher chance to get multiple myeloma than Caucasians. And we also know that men are predisposed to get myeloma a little bit more commonly than women. So there is some answers perhaps in the genetics of male versus female and in the genetics of African Americans versus Caucasians. But again, the exact details, what are those genes, what are those changes that make those difference, is not really known. So again, this is another area my lab is working on. We're trying to model this early disease, these precancerous MGUS cells, and try to understand what some of these changes are. What are these DNA changes that happen? And then if we follow them over time, which ones actually lead to people developing myeloma? If we knew that, we could actually figure out which patients were going to develop the disease and which weren't. And then this sort of gets me to the third area that my lab focuses on, and that is really how multiple myeloma cells actually survive in the bone marrow. So unlike like a lot of other tumors, the environment around the myeloma really dictates a lot of how it behaves. So again, I told you it lives in the bone marrow. So that environment is really important for myeloma. In fact, if you remove multiple myeloma cells from the bone marrow, they die pretty rapidly outside of that space. So we know that the bone marrow is providing a lot of strong signals, and they're so weak when they leave, but when they're in that space, Even things like radiation, heavy chemotherapy, even during stem cell transplant, isn't enough to rid the bone marrow entirely of all myeloma cells. So what about it allows them to have such staying power? So that's one of the things we're trying to dissect, and that is, what are these other cells that myeloma is talking to? And there's one example that's pretty well known, which many patients out there are probably familiar with, either directly or indirectly, and that is the relationship between multiple myeloma and your bone integrity. So multiple myeloma, like I mentioned before, actually sends signals to the cells. There's two kinds of cells. One's called an osteoclast, one's called an osteoblast. The names aren't really important, but the two are in sort of a dance. One is sort of eating away at your bone a little bit, and the other one is rebuilding as the other one removes bone. And that's a remodeling process that goes on all the time. It helps your bone stay healthy and strong. And multiple myeloma dysregulates that process by actually causing an imbalance that makes the bones get destroyed more than they get rebuilt. And that process floods the bone marrow with calcium, which helps the myeloma cells survive and do what they want to do, which is grow and evade the immune system. There's a number of other cells in the bone marrow that are also involved that we don't exactly have a good handle on what they're doing. And so another thing my lab is looking at is, what are those interactions? Can we figure out what signal a myeloma cell sends to another cell, and what that cell then does in response to that? Because if we knew some of these things, we could actually generate new therapies. The same is true with knowing about how myeloma starts. If we had an idea about what genetic causes or what genetic changes occur that lead from an MGUS cell into a full-blown multiple myeloma cell, we could start to develop therapies that target that process. So my lab's focus really is to study these events and then develop new molecular therapies, new targeted therapies against them. Therapies that we could perhaps use to treat patients much earlier than we treat them now, therapies we could use to treat in patients who we know are going to develop the disease, and even therapies we could use for patients who already have the disease. So with that, I think I'd like to transition us into questions. So it's been about 10 to 15 minutes. I know we have a bunch of questions to get through and other things to talk about. If more questions have come up, please feel free to ask. I want us to spend most of our time going through and answering your specific questions.
Okay. Well, thank you, Dr. Hasanali. We have received some great pre-submitted questions, and we want to make sure we can address as many as we can. But before we dive in, we want to invite all those attending today to ask any questions they have. You can submit those in the comment box below or in the chat if you're joining us on Facebook, and we will do our best to cover them all before we finish up. Okay, so I guess we'll start at the beginning. For someone newly diagnosed, what questions should they ask their care team?
Yeah, that's a great question. So I tell patients that they are their best advocate. We have your best interests at heart, but at the end of the day, it is you who's going through the process, and being educated and informed can only help you do better during your treatment course. So I tell patients to advocate for themselves when it comes to specific things related to those CRAB criteria. So if you have low red blood cell counts, or you have high blood calcium, or you have bone lesions, or you have kidney dysfunction, whatever your symptoms are, those are the things that you should be asking your doctor about. How's my organ doing? When they go over the numbers, because they're going to get lots of labs from you all the time. They're getting labs that are checking all those functions. They're getting imaging studies to check on if you have spots in your bones. And it really, I think, helps to ask them what those results actually are. Now, most of your doctors hopefully will take the time to explain to you what all these numbers are. But if they don't, because the visit's going quickly, or there's a really important thing that mattered that they wanted to talk to you about, it's really important, I think, for you to be your own advocate and to ask about those things. Ask about what the study says. If you don't understand something in the imaging study, ask your doctor about what that is. And you should never feel shy or ashamed to do so. A big part of this and going through this process is to know what's happening to you. I've met lots of patients who I've seen in consultation who, it's for whatever reason, weren't as familiar with what their disease was or what they were going through. And it really helped them to understand the process. So no question is too small, but I would say to focus around the things that are affecting you and focus your questions around understanding what your doctor is asking of you. If they're asking you to do a certain therapy or to not do a certain therapy, ask them why if they haven't gone into the reasons. Ask them what your fears are. All those things are really valuable, because at the end of the day, a lot of decisions we make There isn't a recipe book for multiple myeloma. Outside of a few specific situations, a lot of it is stylistic. It's what your doctor's experience has been based on other patients they've seen and based on the patient sitting in front of us. So what about you makes me recommend this therapy that I would probably not recommend to somebody else or vice versa? Those are the types of questions I'd recommend asking.
Okay, thank you. Another question. Since melanoma doesn't appear overnight, are there routine blood markers that a primary care doctor should look for if they suspect something is off?
Yeah, another great question. So the good news is that multiple myeloma is becoming far more recognized, I think probably because of all the amazing progress we've made in treating the disease than it was in decades past. So a lot of primary care doctors now are thinking about multiple myeloma when they see those symptoms, those CRAB symptoms I was talking about, if they come up by themselves. So say you go to see your doctor and they notice that you have a low red blood cell count, you're anemic. One of the tests that they'll send off is your M spike, the SPEP test, SPEP, serum protein electrophoresis. That's the test that comes back with your M spike, which is a measure of that antibody that your myeloma is producing. Because one of the things myeloma can cause is low red blood cell counts. So your primary care doctors now are often thinking about myeloma, not just like, oh, you have low blood iron or any of the more common things, but oh, is this a case where they might actually have an MGUS or a developing multiple myeloma? So what I tell people is if you have any of those things, you have a new high blood calcium, a new issue with your kidneys, new low red blood cell count, or if any spots in your bones, you should ask your doctor to test you for multiple myeloma. And the test for that is a number of blood tests that the myeloma patients know very well, the ones that they get, the ones that are looking for the antibody. And if they don't know what those are, they should reach out to one of the myeloma specialists to help aid them. I have to say, most doctors nowadays, most primary care doctors know what to send as long as they hear the words multiple myeloma come up. So if they're not thinking about it and you have a new symptom that's related to any of those criteria, I recommend asking your doctor if that might be on the differential diagnosis as well.
Okay, thank you. We have some questions here regarding hereditary. How often do you see multiple myeloma run in clusters in families? My dad, myself, sister, and aunt all have had either multiple myeloma, smoldering myeloma, or MGUS. Um,
Yeah.
what do you think?
Yeah, so in general, we don't classify multiple myeloma as a genetic condition in the classic sense, like you would say when you inherit the risk for breast cancer. Um, but there are clearly genetic links, like the one just mentioned. We know of families in which patients actually, multiple myeloma or its other conditions also run in tandem. So what I tell people is there is a predisposition, a risk in your family if somebody has multiple myeloma. So if somebody has multiple myeloma, a first degree relative, so meaning your parents, your aunts, your uncles, um, that sort of, so not your grandparents or great grandparents, cousins, parents, or aunts and uncles, then you have a higher chance of developing MGUS, that precursor condition for multiple myeloma. And because you have a higher chance of developing MGUS, once you have MGUS, you have a chance to develop multiple myeloma. So first degree family members are at increased risk for developing the disease, but those risks are still quite small. So it's not like the case of where people inherit the genes for breast cancer, where the risk is in the range of 30 to 70%, depending on what it is you inherited. This is like a much less clear, uh, much less laid out genetic mapping. So it certainly is important and involved, but by no means does it mean that you will get the disease or that you will even develop MGUS. The biggest risk factor actually for the development of multiple myeloma and MGUS is actually age. The older you are, the more likely you are to have an MGUS, and the longer you have an MGUS, the more likely it is to transform to myeloma because it's had more time to do so. So that's still the biggest risk factor. So the answer is genetics does play a role. It predisposes people, but we think it's actually one of the minor contributing factors.
Great, thank you. You talked about the bone marrow microenvironment. Can a patient-specific bone marrow environment be, quote, mapped to choose a personalized treatment plan today?
Yeah, so that is the holy grail. We're not there yet. Um, we have the ability now in the laboratory to actually take your bone marrow and through some really interesting technologies, look at which cells are which and look at what those cells make. And it's not perfect. We're still, at the beginning of this technology, but it allows us to see a few things we couldn't see before. So we can see it's like looking at a section of your bone marrow, but then also being able to tell what all the cells are making. Um, and that's relatively new. It still hasn't been moved into clinical practice, but we use it in the laboratory a lot to try and study and answer this exact question. Can we look at a patient's bone marrow and figure out if, say, their stem cells that make their blood don't look right compared to the myeloma cells, and could we target that? Or if the cells that make their platelets don't look right or aren't making the right things, and if we could target that. And we're still at the baby beginning stages of working out exactly what don't look right actually means. We know that the myeloma cells are affecting all these other cells and differently in different patients, but it's still going to take some time for us to figure this out. But at the end, that's going to be the goal, to develop treatments against those specific different changes that we see, and then the ability to look to see which patients might benefit. So we're not there yet, but I couldn't give you a time frame because things move so fast, but certainly within my lifetime, we're going to see that as the way that we treat this disease and probably many others.
Okay, very interesting. Thank you. Here's a question about AI. AI is so prevalent in the world today. The question is, are there any biotechs working on solutions where they invoke AI to both fast fail non-starter solutions as well as to identify the higher probability of success candidates?
Yeah, absolutely. So I think this goes part and parcel with the huge revolution that's occurring in the chemistry space right now in drug development. So a lot of companies have their own proprietary softwares that use AI to model which targets might be the ones to go after, and then which drugs might be the ones to use against that target. The real issue, I think, still that we're having is we're only as good as how much data we can feed into it and the quality of that data. So, to give you an example, we don't know what all the different proteins are that the myeloma is making that's leading to all these changes in the bone marrow. So if we knew what those were, we could feed them into an AI model, and then it could help us find chemicals, drugs that might fit that protein to block it. But we're still in the phase where we're discovering what those things are. And AI isn't really very good at this point at doing creative discovery like that because it doesn't do experiments just yet. So right now, it still depends on us in the laboratory to ask that question, develop that research tool, and accumulate that data before the AI models can look into it. Now, where really been able to speed this up, though, is in the drug part I was mentioning. So in the past, what you'd have to do is you would take a big library of a million different chemicals that are already made, and you would treat a myeloma cell with each chemical and see which chemicals killed the cell or which ones didn't. And that's a pretty brute force method to try and figure out a drug, and it has a low success rate. So what we're doing now is allowing AI and these bigger models to actually take a protein, look at the structure of that protein, the 3D structure, what that protein looks like at a super microscopic level. And then it uses software to actually stick different molecules in different parts of the protein to try and block its function. And it does this all in the computer. And then it comes up with these types of chemicals look like they might be good for this type of protein. And so then you use that to then develop those chemicals and then use those to try and treat that target, as opposed to just randomly trying to choose ones by a blind screen. So that process has actually really helped, and I think it's accelerated our ability to get molecules into the clinical trial space. And then that's a whole nother discussion. How do we speed up clinical trials? Um, that's an ongoing discussion between the FDA, researchers, all this sort of things. I think there was another piece of a question related to that. And that's a little bit harder. We've gotten a lot faster. So the time it takes for drug to go from beginning to end is on the order of 5 to 7 years instead of 7 to 10 years, but it's still years and not months. And that's probably still going to be the same for the foreseeable future. A lot of it has to do with regulation and safety.
Okay, thank you. We'll now turn to a question about little older patients. What determines the risk versus benefit of aggressive treatment in geriatric patients?
Yeah. So I think this is somewhere where that art of medicine comes into play. So ideally, I'll give you an example to illustrate this. Ideally, every patient that shows up with multiple myeloma, the first treatment they would get would be the same, 4 drugs in combination. That would be the best treatment we know by study. It gets the best treatment response, and that for one of the few things in the field of multiple myeloma that's really not questioned at all by all myeloma physicians. We all agree that this 4 treatment regimen is the right one to start with. But there are some issues that might come up. Say you had diabetes and that created neuropathy. Many myeloma patients know what neuropathy is. If you have diabetes, you know what that is. It's sort of a damage to the nerve endings that causes a numbness and tingling. Sometimes, if it progresses, leads to inability to walk and more severe things. So if you have that already, one of the side effects of one of those drugs in that 4-drug combination I just mentioned is neuropathy. So I don't want to make it to where, yes, your disease looks like it's getting under control, but now you can't walk the rest of your life, right? Whereas you were an avid runner before or what have you. So these are the types of symptoms or pre-existing conditions that a patient might have. And our older patients tend to have the things like neuropathy that come into play. So in that case, I'm not going to give you that one drug because the chance that it causes you harm is really high. And then it turns out that if I give you a 3-drug regimen instead, the response rate is still really high. It's not as good as the 4-drug rate, but it's not like it's 20% versus 90%. You're talking about difference between about 90% and 80%, say. So less, but still quite high. But it's these sorts of factors that we're taking into account. What are your blood counts like? What are you able to tolerate from a nausea perspective or a diarrhea or constipation perspective, some of the drugs that you're getting? Can we manage infections? All the treatments of multiple myeloma predispose you to infections, some more than others. And those are one of the things that we worry about a lot because the number one killer for multiple myeloma today is still infection. So we're weighing a lot of these issues. If we think that one of the drugs we're going to give you is going to cause you more harm than the potential good it could because we have so many options to treat you, that's where we might not give you all 4 drugs up front, or we may recommend a treatment for you down the line that perhaps we wouldn't recommend to another patient or vice versa.
Great, thank you so much. This one is, I think many people wonder about this. Why are melanoma cells so effective at adapting to treatments that worked initially?
Yeah. So this is a question we get in cancer in general. There are very few cancers out there that we can cure with just chemotherapy or any therapies that we have currently. And I tell people to think about cancer like bacteria, right? It's the same idea. They no longer care about the whole. Each one is in for itself. Your normal cells behave like they're living in a family. They grow like they're supposed to. They die when they're supposed to. They care for their surroundings. Um, all of these, they're mindful in a way of the rest of the organism. When a cancer cell develops, it loses that understanding and really only looks out for itself. It wants to do what it wants to do. It wants to grow, it wants to divide, it wants to use all your resources to do that. And so, because the DNA, the messages that tell that cell what it is, are unstable in a cancer cell, much like a bacteria cell, when you use any sort of therapy, you put a pressure on that cell, on the cancer cells. And the cells, because their DNA is unstable, they're mutating all the time. And so just by chance, because there's so many millions of them, one is going to mutate in a way that protects it from the treatment that you're giving. And this happens inevitably to basically all the therapies that we use. And we're still trying to understand, there should be a point, if you really think about it, there should be a point where we reach something that's so fundamental that the cancer cell can't mutate it or it'll kill itself. And every few years we talk about what that thing is, and it turns out to not be the case. Cancer cells are very wily in that way, just like bacteria. You keep using antibiotics with bacteria, they develop resistance, and eventually they grow through it. It's the same idea with cancer cells. So we've sort of taken a different approach across cancer in general, and that is that we're trying to focus on how we can use the immune system to get rid of the cancer rather than us killing it directly. And while killing it directly is still good to reduce the amount of cancer that's there, our only real shot at cleaning your body of all the cancer cells has to come from awakening the immune system, because that was what was supposed to find it in the first place. Um, so that's what a lot of these new therapies, CAR T cell therapies, bispecific antibody therapies, all these fancy ones that have come down the line now that many of you out there who have gotten or have heard about are aiming to do, is to weaponize the immune system to come in and see if the immune system doesn't necessarily care what the cancer cell is doing. As long as the cancer cell can't hide from it, it's going to destroy and find it. So I think by putting more of our effort in activating the immune system, we're going to do a much better job at overcoming this resistance that cancer cells innately develop. And that's not just for myeloma, but for cancer at large.
Okay, thank you. A couple of questions are what gives you the most hope right now in melanoma research?
Yeah. So I think the thing that gives me the most hope by far is not just the therapies we have, but the way that the therapies that are coming look. So in the past, when we've developed new therapies, those therapies have been developed, and then the things that come after them aren't necessarily that much more exciting or that much better until somebody makes another big breakthrough. I think to me, for the first time, that's not true. When a lot of these CAR T cells that are currently approved, or these bispecific antibodies that are currently approved were approved, a number of other newer generations of those drugs were already in clinical trials. And many of them are already close to getting approved by the FDA. Things like CAR T cells that have far fewer side effects, bispecific antibodies that they're not even bispecific, they're tri-specific antibodies. They bind to three things so that the tumor has even less a chance to get away. These sorts of therapies are showing profound response rates in patients that are relapsed and refractory. So we know that in early lines of therapy, most people will respond to most treatments. But when you get into your fourth, fifth, sixth line of therapy, the chance that you respond to any one therapy goes down considerably. But even in those patients, we're seeing pretty high response rates with all these new therapies that are currently in the pipeline. That's where I get the most hope from like a drug development perspective. The other thing is, something that my lab focuses on is we are discovering and developing new models to study myeloma before we get to the drug development point. So we're only as good as are the models that we have to study the disease, right? If I can't model multiple myeloma in the laboratory, how can I actually figure out drugs and things like that that I can use against it to study it? Because it's of course unsafe and unethical to just experiment on patients in this sort of way. So we have to develop other models to do it. And for the first time in 3 to 4 decades, we have new models that might actually give us this ability. So I'm certainly biased because it's the research that I work on. But I think that we have a lot more to offer now that in the preclinical drug development space, because we develop new models that can look at the disease and interaction between the disease and the microenvironment, or the disease and your T cells.
Okay, thank you. How can patients and families stay informed about clinical trials and new treatment options?
Yeah. So I'll give you three ways to do that. So the first one I think is to ask your multiple myeloma specialist. So I will put in a plug for multiple myeloma specialists like myself. If you have been diagnosed with multiple myeloma, even if you're being treated locally by your local oncologist, I encourage you all to be seen at least once by a multiple myeloma specialist, first and foremost. And that's because inevitably, to this day, multiple myeloma will relapse, even with the treatments that we have. And we want to have the ability to give you the most cutting edge, appropriate therapies. And many of them can only be given at big centers like here at Indiana University, downtown Indy. So if you haven't seen a myeloma specialist for your disease at least once, I encourage you to do so. They should be your first source for what's out there, what am I a candidate for in terms of trials. Say I get to the point where I need a clinical trial. The other therapies haven't worked. What clinical trials are there out there for me? A way, if you want to empower yourself to do that, the Multiple Myeloma Research Foundation, the MMRF, has a site in which they've collated all the clinical trials available in the United States for multiple myeloma patients. So if you wanted to know what are all the trials at all the centers around the country that are currently active, the MMRF actually does that. They collate all those together on their website. The third place, which is more generic for all clinical trials, the United States FDA requires every clinical trial in the United States to be registered on clinical trials, so clinicaltrials.gov.gov. If you go to that website, anybody can look at it. It's a public site. You you can search for trials by disease. So you can type in multiple myeloma and see what trials are there. It's a lot harder to navigate because it contains all the trials for every condition. Um, but if you're savvy with being able to use your search terms, you can narrow it down to myeloma. That's the reason why I put a plugin for the MMRF website, because they've kind of already done that for you. So I think your myeloma doc is your first person to go to, because they'll know for you specifically what trials are available. If you think that there might be one that you would be a candidate for, that's not necessarily open at your center, you can still take it to your myeloma doctor and say, do you think I would be a good candidate for this trial? Because a lot of times your myeloma doctor knows myeloma doctors at other centers, and they can help you get plugged into that trial if you'd be a candidate. So really, it's about keeping that line of communication open with your myeloma specialist and educating yourself based on these two resources I just mentioned.
That's thank you. Very helpful. Um, is it possible that using immunotherapies like CAR T or bispecifics, that they work better in the precursor stage rather than in late stage relapse? And is that on the horizon?
Yeah. So this is heavily debated right now in our myeloma community. When we have our conferences, there's two schools of thought about treating early or not treating early. And part of it is what I mentioned regarding the fact that many people who have these precursor conditions like MGUS or smoldering myeloma, which I didn't mention before, smoldering myeloma is basically an MGUS state where you have more plasma cells in your bone marrow than you did before, but you're still not showing signs of disease. So there's a whole camp of thought that is looking and saying that there are certain patients that are really high risk of turning from the smoldering multiple myeloma into full-blown multiple myeloma. And in that population, there are trials ongoing with some of these agents, as well as some of our standard agents, and treating them earlier to see if they live longer overall. And like I said, there's a lot of debate. It's not clear whether the answer to that question is yes or no, depending on who you talk to in the myeloma community. When it comes to treating MGUS, the early precursor state, I don't think any of us are really huge proponents of treating that just yet, because we don't have a great way to determine which of those patients are the ones that are going to transform and which ones aren't. And so we would be giving a lot of toxicity to those, a lot of side effects to those patients who would never develop the disease, so that we could catch some people that might earlier. And so that's a tough, trade-off to work through. I do think that we do know that using these therapies earlier in multiple myeloma is looking good. So when some of these CAR T cells were approved, they were approved in the fourth and fifth line of therapy. Now the FDA has increased that approval to second line of therapy. And we know that patients who get these CAR T cells earlier have less side effects, and it looks like they're doing better overall. So bispecific antibodies are currently in clinical trial in the second line as well, showing really, really strong responses. So it might be that patients will actually start to get these early, much earlier once they have the disease. And it's looking like the outcomes may be better too, though it's still a little early to tell. If we can show that we can figure out which patients are going to develop from these precursor states like MGUS or smoldering myeloma into myeloma, I do think that will move these advanced therapies like bispecifics and CAR T into those diseases. But we got to be able to confidently figure out which patient's going to progress and which patient's not.
Okay, thank you. Um, this question, there's two of these. Some people have developed another form of cancer after being diagnosed with multiple myeloma. One question is, I have lung cancer. Is there any relationship to myeloma? Another question said they developed a thyroid cancer and also a salivary gland cancer. And they wonder, is there a link
Yeah,
between those and multiple myeloma?
great question. So I think about it in two ways. So genetically, it's possible that you're predisposed to develop a cancer if you have gotten multiple cancers in your lifetime. It's possible. I can't say with any level of certainty that that's the case, but we know genetics play a role in protecting you from the mutations that cause cancer to your DNA. So it's possible that you have a little bit of predisposition, not a full-blown cancer syndrome like we've been able to qualify and quantify in some people, but perhaps a predisposition. The other thing that's probably more likely, I think, is that your immune system is what is responsible for clearing cancer cells from your body normally. So every day people are developing cancer cells in their body. And every day your immune system is finding them and killing them before they ever become a real cancer. You never even know it's happening. In order to develop cancer, your immune system has to break in some way. It has to be blinded to the cancer so that it can actually grow with impunity. So somebody who has multiple myeloma has already developed one cancer, meaning the immune system is broken so that it's not able to see that cancer. So the chance that your body can develop another cancer is higher because your immune system is not working nearly as well. And then, not to mention, the only way to really treat the multiple myeloma is to further affect your immune system with the therapies that we have, because the plasma cell that is the myeloma cell is an immune cell. So one of the side effects is immune suppression. And that can increase your risk for other cancers, specifically things like these salivary gland tumors, superficial skin cancers. These sorts of things occur more frequently in myeloma population, and we do encourage patients to get their skin screened by dermatologists just to make sure that those can be removed early before they cause problems. So two parts, some genetics probably, but then also the fact that the immune system is no longer seeing all things that it should be seeing as cancer. So your chance to get something else is higher. And then I'll make one other point about lung cancer. So lung cancer isn't classically thought of one of those cancers that goes hand in hand with myeloma, but there are similarities between the two. As far as blood cancers go, the mutations or the genetics of a blood cancer are far less complicated than the mutations or genetics of a solid tumor, like a cancer or like a lung cancer. But multiple myeloma sits in the middle of these. It actually has a lot more mutations and DNA changes than other blood cancers do. Probably part of why they're also a little bit harder to treat than some of the other blood cancers out there. They behave like a solid tumor and a liquid tumor all in one. So, a little bit harder to deal with than anything else.
Okay. Um, what's the biggest misconception about how melanoma develops that you wish more patients understood?
Yeah. So I think the biggest misconception is around this precursor state. So a lot of people, the precursor state and exposures in their environment. Actually, I'll talk about that a little bit first, because that's a question I get all the time. What did I do or what happened to me that I ended up with this disease? Like, if I had not done X or if I had not done Y, then I probably wouldn't have this, right? And I want to really put out there that it's nobody's fault, nothing that they did that we're aware of that caused their cancer. Okay, so even if you were exposed to a chemical, again, most people who are exposed to chemicals don't develop the disease. Most people that are overweight or obese don't develop the disease. Most people who have a first-degree family member who have multiple myeloma don't develop myeloma. So it's not that you did these things and that you now have the disease because of it. Um, it's sort of one of these things we don't understand. Why do people get cancer? That's an open question, um, still open for study across the board. And in myeloma, that's also true. So look forward, don't look back at those reasons. There's not really nothing you could have done that we know of to attenuate your risk or make it less likely that it happened. And the good news is that we have great treatments that can give you a long life expectancy with a good high quality of life.
Okay, well, I think I have one more question for you. If we fast forward 10 years, what do you think melanoma treatment and prevention will look like?
Yeah, so I'm hoping that treatment will look, I mean, I can't even guess because it's moved so fast what treatment will actually look like. But my hope is that we'll be able to use things like we'll have all sorts of different CAR T cells and bispecific antibodies, things like that, to all sorts of different targets that we can move from one to the other, and they'll have side effect profiles that are much better. There is a CAR T cell that's coming down the road, whose data has been published in the literature already, that hopefully will get approved in the next year or two. That's going to have far fewer side effects than the ones we have now. And that's going to give us the same level of benefit, but far less side effects. So that's what I'm really looking forward to. Um, from like a laboratory standpoint, I really want to see, and I know all the patients out there want the same thing. I want to see a cure for the disease. Something that's finally like not a functional cure, which we're working on now, which means we can treat you maybe twice in your lifetime, and then the treatment the disease in remission for so long that it won't matter, but something that we can do to actually kill the disease early. And that's sort of what I'm focused on. Can we kill the disease early such that it's gone entirely? And if we can develop a drug or drugs that are able to do that with a very low side effect profile, I think we'll have something to move forward with. And stay tuned. Hopefully from my lab, you'll see some of those things come out in the next decade.
That's wonderful. Thank you so much. And that concludes our questions. So I'd like to, I guess you have a conclusion
Yeah.
for us?
So I just want to say thank you, Eileen, for moderating. This has been a really wonderful experience. I hope I was able to answer many of your questions. And feel free to reach out to your myeloma physician if you have other ones. And if I see you in the hospital, definitely feel free to say hi. You saw me on this. It'll make me feel real good. And before we close, I want to tell you about an upcoming event that I'm personally inviting everyone to attend. Research is a marathon, but on Sunday, May 17th, we only need you to go a mile for myeloma to make an impact. I'm inviting you to join me and my fellow IU Simon Comprehensive Cancer Center researchers for a free 1.5 mile walk at the Crown Hill Cemetery in Indianapolis. Together, we can fuel IU myeloma research. Again, registering is free, and if you donate or fundraise $100, you'll receive a free t-shirt just to say thank you. So please ask your friends and family to join on the walk or to support your effort with a donation. We'll send out an email after the webinar today with a link to register and information on how to get in touch with our team to fundraise. Thank you for joining us for this month's Simon Says. You can find a recording of today's session and information about upcoming sessions at cancer.iu.edu/Simon Says. Have a great day, everyone. Thanks for tuning in.